Hi everyone, welcome. As people are trickling in, we have a Mentimeter to just get things started here. Tim and I, my name is Kelly, Tim is my co-moderator, and we really want this session to be as informal as possible. So if you could, there we go, you know exactly what to do. Feel free to scan that QR code or join at menti.com and use the code up there, 83163787, to answer the question, how optimistic are you about the future of global migrant health equity? So we'll keep this question open for a few minutes. We have two more questions for you all to answer, but we'll just keep this question up for a few minutes as people trickle in. Thank you. Thank you everyone for contributing. So far we have over 20 responses to the question, how optimistic are you about the future of global migrant health equity? Most of you are somewhat optimistic. We have one very optimistic individual and 7 are not optimistic. We can change 7 of those individuals' minds after this session. If we could go to the, if we could go to the next question, please. Thank you, Ha. So the second question is, what do you think about the future of migrant health in 5 to 10 years? Do you think it will be much worse, better, much better? Great, thank you everyone. So the majority of you think the future of global migrant health will be better in the next 5 to 10 years. And we have also a smattering of people thinking it will be the same, and a few people thinking it's going to be worse. This is very good information to have for the beginning of our session. And if we could go to the next slide for the last question. This one is an open response for you to answer. Okay, perfect. Thank you, Ha. So for this question, in your opinion, what is the biggest barrier to migrant health equity and or the most urgent policy gap? And if you could answer in just a few words, that would be great. Okay, we have one response already, politics, the biggest barrier to migrant health equity. Commitment, legal issues, another policy issue. Okay, financial burden, stigma and discrimination, corporate capture, political will, a lot of political will. Okay, thank you everyone for participating. So with that, I'm going to hand the mic over to Tim, my other co-moderator, to kick us off.
Wonderful. Well, Kelly, thank you for getting us off to an exciting start to this session. For all of you that are here, this is the most important session at PMAC. So if you have friends out there that aren't here, you can text them and say, make it over to World Ballroom C, because this is going to be the best session of the week. But seriously, welcome. Well, it's actually hard to overstate the importance of what we're going to talk about today. You know, it's our session, Migration, Labor, and the Health in a Changing Planet, addresses what I think really is among the most important problems facing the world in global health. And we've thought about that this whole week of how important this is, the issues of wealth inequality, forces from the climate, people moving around. But as you'll hear from our experts here, our two plenary speakers that I'll introduce in just a moment, there's more than 300 million international migrants in the world now. But as we heard yesterday, if you saw Chris Murray's talk about the demographics coming from the global burden of disease, it's going to get worse. The wealth inequality in the world is going to continue to increase. The forces for migrants to move along with that as populations change and climate changes. I like to think that whenever there's a gradient, there's going to be a flow, whether that's particles moving down a gradient, or in this case, you're going to have gradients of wealth inequality, and people are going to follow that for their own economic needs. So there's going to be increased numbers of displaced people within and outside of their country of origin because of conflict, violence, political or economic instability, as well as climate change. There'll be more disasters leading to increases in numbers. So during this 2-hour session, we aim to address and unpack the issues that are playing this and identify actionable items. And we're going to have very active audience involvement towards the end of the session, but really want you all to leave Bangkok and go home. And whatever you're doing in your professional capacity, take the messages from this session that you can apply to your work, be advocates for addressing issues of global climate change and migrant health, and deal with those issues. So I'd now like to introduce my co-panelists for this session. Kelly Perry is a Thai-American researcher, writer, and advocate from Chiang Mai, Thailand. Kelly's currently a PhD student at Duke University's Nicholas School of the Environment in Durham, North Carolina. Her work in Thailand, Africa, and the US has addressed environmental health inequities associated with exposure to environmental hazards and pollutants, particularly in the context of climate change. Kelly holds an MPH from the University of North Carolina at Chapel Hill and a bachelor's degree from Vanderbilt University. Kelly, come on up here and you'll introduce our two keynote speakers.
Wonderful. Thanks so much, Tim. Okay. Hi again, everyone. Great to be with you all. Without further ado, I'll introduce the people who you are really here to listen to. So the first keynote speaker is Dr. Poonam Devan. Dr. Devan is the director of the Migrant Health Division at the International Organization for Migration, IOM, in Geneva, Switzerland. In this role, she provides strategic leadership and oversees all migration health programs. She is responsible for IOM's migration health policies and represents IOM internationally, working closely with member states, UN agencies, and other stakeholders. Dr. Devan trained as a medical doctor at the University of Mumbai, India, and has further specialized training in health administration and public health. Our second keynote speaker, Dr. Santino Savaroni, has been head of the Health and Migration Special Initiative at WHO headquarters since 2020. He's a medical doctor, health economist, epidemiologist, and systems manager with over 24 years of experience. His areas of expertise include global health, health sector reforms, health system strengthening, health diplomacy, aid coordination effectiveness, and management of complex emergencies. So without further ado, I'll hand the mic over to Poonam to give the first keynote presentation. Poonam, the floor is yours.
Good afternoon, everyone, and let me join the moderators in thanking you all for making time to be here at our session today. We understand it's almost the end of the conference, and really appreciate your time and attention. So I'm very happy to be here speaking on behalf of the International Organization for Migration, and would like to also deeply acknowledge our gratitude to the moderators. They are not just the moderators, but they've put in a lot of effort in organizing this session on a very important topic of migration and health, as well as PMAC, the hosts, and the Thai delegations. We also have colleagues in the room here. Thank you very much. So, as most of you know, and we have also heard through the course of various sessions here this week, migration is a phenomenon that is very much present in our times today, but has also been impacting social, health, and development sectors for several decades before us. Migration remains a very dynamic concept. And as you will see here, there are, of course, a range of drivers from individual to sociocultural and economic to environmental or security-related drivers that lead to people and communities to migrate. Similarly, migration occurs across different varieties. It could be internal migration versus international. It could be forced or one of choice. And with these drivers, we also see many different contexts in which migration has occurred over centuries. These have also always been dynamic. Some recent factors, of course, include the increasingly changing and often restrictive migration policies with fewer regular pathways or legal migration routes, changes caused by increasing conflicts with new geopolitical dynamics that often strain existing response systems. We also have the modern factors impacting this context, whether it's unregulated or inequitably accessible artificial intelligence or technology that is also transforming governance, but also resulting in a lot of mismatch in capacities or misinformation. Changes in economic situations. So with widening economic gaps, we also see a surge in those drivers that I mentioned before. So there is a lot of dynamism, there is a lot of change in context, but at its core, at the population level, what it means is that the reach and access for people most in need is becoming more and more complicated across the board, not just for health, but also for other sectors. In terms of numbers, as you already heard, 1 in 8 people worldwide is on the move in terms of international migration. Overlay this also with other factors I mentioned before in terms of internal migration. As IOM, we also track population mobility at the very local level, within and across countries. We track displacement through tools such as the displacement tracking matrix. So all of this data shows us that there is a significant amount of population mobility occurring, especially within regions, in addition to and in much larger numbers than international migration. Looking also at our session today, where we are examining this intersection between migration, labor, climate change, and health, some statistics here from ILO. I'd like to emphasize here how data is starting to emerge also in terms of where migrant labor is working, primarily in terms of sectors. What are the gaps, not only in terms of compensation, but also in terms of wider social protection for labor migrants? And then, of course, the identified and documented risk in terms of forced labor or exploitation. Similarly, and increasingly, we are utilizing geographic information systems, overlay of data from multiple sectors. And here's just one example from the Asia Pacific region in terms of how there are multiple and often mixed migration flows. So it is really a highly interconnected and complex phenomenon and cannot often be categorized into simple definitions. Now, within this context, of course, when we speak of migration and health, there are multiple agendas that have to be considered. At IOM, as the UN Migration Agency, we emphasize the role and importance of health across multiple sectors. And this, of course, means working across the migration, the development, and also the global health agendas. In terms of migration, as the coordinator for the Global Compact for Migration, we also see how important it is to work with multiple sectors or different agencies. Similarly, when we think of the SDGs, of course, not only do we have the emphasis on SDG 3 in terms of health as global health professionals, but it's important to look at how the world is interfacing the achievement of health targets with SDG 10 or 10.7 specifically in terms of inequality or also access to safe and orderly migration. And then the global health agenda, of course, which Dr. Santino will further tell us about coming from WHO. But here I did want to emphasize the increasing importance of the global health security agenda or pandemic prevention, preparedness, and response, which becomes a key area of work when we think of population mobility. So across these contexts and across these global agendas, as IOM, we are constantly trying to identify how we can better achieve the positive potential of migration while still being able to reach and serve populations in need. The strategic health focus that we have here is across three key objectives. One is integrating health such that we are able to save lives and protect people on the move. Secondly, health system strengthening and anticipatory work for health-related risks, for instance, in climate change context, in order to deliver solutions to displacement. And lastly, facilitating pathways for regular migration so that we can promote the health and psychosocial well-being of people on the move. In this next part of my presentation, I would like to just highlight three selected areas to give you some operational perspectives on what we see in terms of the strategic health focus meeting the real-world migration. So first and foremost, it's important to note that health is indeed a cross-cutting area that cuts across and connects many different aspects of migration. Whether it's around identifying vulnerability, whether it's around strengthening preparedness, or linking physical health to mental health and psychosocial support-related work, it becomes a strategic entry point to address various migration governance issues. To exemplify the importance of continuity of care across borders, for instance, just an illustrative case here, working in Southern Africa at the Mozambican borders with South Africa, where we see how local health systems are trying to connect mine workers with the health services and social protection they need. Occupational health screening takes a whole new meaning when you have workers moving across borders, sometimes daily, sometimes seasonally, and how this links also outside the health sector, for instance, with social protection when it comes to facilitating access to compensation, also working with employers and public sectors. Secondly, health is a foundation for labor markets. When we think of the future of work, human mobility is going to be even more essential, whether in the care sector, in agriculture, construction, and beyond. Healthcare also shapes how well a migrant can participate in labor markets, work safely, and productively. So without health, labor mobility does not actually deliver the economic benefits that it is intended for, but only transfers risk. And this is where we also want to emphasize the positive potential of working with diaspora, with migrants and communities themselves, who can also enable investments in health system strengthening at source. Workforce mobility and health systems, of course, the topic of human resources for health and how to better address gaps both within and between countries is becoming another key area of concern. Here, just some statistics from our Migration Governance Index that has been trying to track how well bilateral or regional labor agreements for health workers are addressing some of the challenges, including how to invest in medical and health education in source countries. And thirdly, and importantly, health also as climate adaptation and resilience. This is a topic really where climate change, human mobility, health system strengthening all interface and demand that there be migrant inclusive health approaches. Whether we are talking about climate adaptation measures, whether we are working even at the local and community level in terms of resilience and response for those who may be forced to move as a result of acute or chronic climate events. We will, of course, have an expert on the panel later on today speaking to this topic, but I just wanted to also share some of our work in action in terms of how to embed mobility lens when looking at public health and climate-related action, whether it's around research, whether it's around building those bridges amongst different sectors, even within the UN system, that are starting to look at climate-related action. So, in conclusion, I'd like to leave you with this very broad question and a few points for discussion. Let us really think about how prepared are health systems for human mobility. We do have stellar examples, which you will continue to hear in our session from several countries and also local communities. But this is really a key forward-looking question for those of us who want to make advances and who want to progress in terms of achieving health-related targets. How do we build migrant-inclusive health systems? How do we embed public health measures when you talk about fair, ethical, regular pathways for migration? Coordinated governance and cross-border cooperation. We've all seen through the COVID pandemic in our respective areas of work how that needs to be strengthened so much more if we are to be prepared to respond better in future. And how do we harness diaspora skills better, investing and strengthening in professional networks in order to reap those benefits for the health system itself? So I just wanted to end by saying that as IOM, we remain committed to continue to integrate health-related work across all our areas when it comes to migration governance, whether in humanitarian or development settings. And I'm looking forward to the discussion later in our session on how each of us in our own respective humble roles and positions can advance this area in a changing planet, as the title of our session also calls for. Thank you.
Thanks so much, Poonam, for that truly excellent presentation. I know you're all probably boiling with questions and excitement, so we're going to have Santino come and give his presentation, and then we'll have a short Q&A just with our keynote speakers before we move into the panel. So Santino, the floor is yours.
Thank you, Kelly. Thank you also for your kind introduction, and team for the invitation here today. I don't have a real presentation. I thought to put together a few slides to give you few facts and flash on what is the situation in relation to public health. Considering that we started to work as a WHO on this topic when most of the health sector, most of the Ministry of Health were not considering migration an issue relevant for public health. The attention was turning towards migration only in case of crisis, in case of the migratory process was presenting issue of public health concern. And we realized a few years ago in WHO that that was not enough. It was necessary to start to look at the long-term implications. In these 5 years that the program was established in the WHO headquarters, we have done a lot of work together with our member states, and today I'm anticipating, especially for PMAC, few of the findings of the second report will be published in about a month in Geneva. I think you are totally familiar with those numbers. I don't want to speak about numbers, but I want you to read with me in between those numbers. What is the meaning of that? Those are looking massive numbers. In reality, if we're going to look what is the increase of migrant population in the last 10 years, it's 0 point something. So we are on a very steady, slow growing of the migrant population. Situation which is not like that for displacement, which is quite massive indeed. And then we are having area of blurring reality. We are having area where we don't know exactly what situation is, like internal migration or even irregular migration. Those groups are categorized like that by governments with the aim to codify them and to define the type of services, entitlements, which they can access once hosted at the destination. And here is the devil into details, because those definitions, they are actually based, or the base for a legal framework, which is deciding or determining the level of entitlement to healthcare services, and not only. A lot of attention, especially from media, goes to irregular migration. And in most of the cases, because there are important reasons, disaster, people losing their lives in the very dangerous journey towards the northern part of the world. But very little attention is posed to the main cause of migration, which is economic reasons. It's basically to try to find better living conditions. So labor migration is most important. And again, please read with me in between the numbers or in between the lines. If you consider 304 millions, of international migrants, we are considering that big majority are represented by labor migrants, but then when we go to ask to member states what is the situation, the labor migrant actually registered means they are officially monitored in the country, and as a consequence contributing to health insurance schemes, accessing services, accessing GPs, are actually much lower than what we are suspecting. So there is a gap of reporting, a gap of monitoring, gap of having clarity on what is the size of this population. And this for us is a big problem because, let's be very honest, from the health system point of view, when we want to expand access, means we need to make an investment. And in the health sector, we are investing not because we are looking to a profit, but is a control loss type of investment. So we are investing because we want to generate, our profit is generating health for the population. And having this fragility of numbers is a big, big problem. Here you see also a bit of distribution around the world, but I'm not going to go too much in details. I'm proceeding pretty fast in the interest of time. I mentioned at the beginning, displacement is a totally different story. Actually, we are reaching numbers which are higher than after the Second World War. And the problem is that those phenomena, they are bringing with them big concern in terms of ability, capacity of the government to manage those sudden large influx of people crossing borders, or even more internally being displaced. And usually the attention is for displacement across border, much less for those which are trapped into the border of a country in a conflict. This was the example in the case of Syrian crisis, where a lot of attention was to put at the 400,000 Syrians migrating towards Northern Europe, but there were almost half of the population trapped in Syria and having big difficulty to receive the basic healthcare support. Another important element is that displacement doesn't happen from poor countries towards rich countries. Displacement happens in the neighboring country. People try to save their lives. So we have a moral and a public health responsibility to assist those countries which are actually renting a service for the entire world. Let me give you some example. Lebanon, Jordan, 1/3 of the population is represented by refugees. Or at the moment, Egypt is hosting millions of Sudanese refugees. So those are countries where we're supposed to devote our attention, have an approach of shared responsibility, and support the health system of those countries, because in the interest of public health, if you have a point of fragility, it means we are having entire system, the entire world system, fragile in terms of health outcomes. Climate change, there is a lot of speculation mentioning about numbers, but those are simulations. Again, those are projections. So those numbers are beautiful, but we don't have any solid evidence that this is going to happen. Actually, again, it's interesting that the studies, and today was also mentioned in the plenary, shows that the main concern are for the trapped people into area of climate change, which don't have alternative to migrate. But there is another interesting information for us, for public health, that while when we are dealing with health and migration, and we are discussing with the health sector the issues, the intersection between health and migration, the word migration bear always a meaning, a negative meaning. It's very difficult. We need to be always very, very careful and very diplomatic in bringing up the issue of migration. When we are talking about migration in the context of climate change, there is a perception of positiveness, because migration is an adaptive phenomenon. So this is a very interesting point of speculation and discussion, why we are having this completely different approach. And again, the most important element is that while we do know a lot about how climate change they are influencing the pattern of diseases, we are not doing much in terms of experimenting or designing resilient health system or inter-country collaboration in order to have health system able to support the population which are trapped or which are migrating across border because of climate changes. All those informations I'm giving you flash from the finding of the World Report, which we're going to release beginning of March. We produced the second report looking at the first report in 2022, where it came clear, analyzing a massive number of worldwide evidence, that there was an issue of data, there was an issue of access health system, there was an issue of coordination between the different actors in the government in terms of addressing the health dimension, and there was still, allow me to say, shy attitude of the health sector in engaging into this topic. Few years later, we thought important to really try to make a Polaroid picture of what is the context on the ground. So we started last year the production of the second report. We developed a questionnaire in order to collect information directly from member states. The question is built around the indicators that we've been identifying to monitor progress in implementing the Global Action Plan, and we asked to all countries to respond. Interestingly, because this has been surprising us, 93 countries responded to those questionnaires. Really, for us, an important number. We were expecting much, much less attention, and this was the health sector of these countries. And the result has been that most of the countries, a lot of progress, but still area where improvement is needed. Most of the countries, they start to include refugees and migrants into national policies, but still we are experiencing some area of gap or caveat where the issue of migration or the issue of refugees' health, they are not addressed. There is no systematic evaluation. Countries do not conduct any assessment. They are not going and monitoring what is changing at country level. So if we don't do that, how we can allocate resources? How can we plan different type of health services for these people? So it's extremely important to start to look at the changes and to start to understand the changes. Data remaining a challenge, not because scarcity of data, but because of fragmentation of data, which doesn't allow us to compare. The journey has been quite short, even if the slides can give you an idea that it's a long time we are working on this topic, but usually I'm putting these slides for two messages. that health sector was at the window, watching the issue related to health and migration until 2008. We started to work on this topic in 2008. And the approach was emergency response. So in this year happened a paradigm shift where instead of responding to an emergency, we understood that we need to bring the issue of health and migrations, the public health concern related to migration, into the health sector in order to look into the long-term impact and long-term setting of the health systems in response to the needs of the population, but also of the society where the migrants and refugees are hosted. We have a policy framework. Without that, we could not act. The policy framework is articulated around 6 priorities, which are covering the entire public health domain. But we thought important also to develop or to put in place accelerators in order to tackle elements related to governance, elements related to research, data, normative work, and technical assistance to countries, but also partnership, collaboration with partners, because the migration agenda is a multi-sectorial, and as we are only focusing on the public health dimension. Another important achievement, which in my view is extremely important actually, because as a very relevant fallout on our member states, we managed to include health and migration within the priority of the WHO General Program of Work, which is the WHO Global Strategy, with outcome and output and indicators. So this will generate a fallout on member states in terms of engagement, commitment, and you can see from the data there of the number of countries which they start to prioritize this topic in developing national plans of collaboration. We are carefully observing what's going on at the country level. We have a dashboard developed for that. It's a dynamic process. Every year we are collecting new cases from member states. And we want to see what's going on, but also we want to offer to member states experiences where they can learn from. So facilitating cross-fertilization, cross-exchange of experiences. All this doesn't happen without challenges. We're keeping working on this topic, despite not only us, but also IOM and SCR. This year we had to meet an enormous cut of our budget, and it was interesting that health and migration was one of the topics which was at risk. So complex issues sometimes are, in a moment of difficulty, really risking to disappear from our public health landscape. There is this beautiful article from Lancet, for whom is interested to know more. This is available on internet. I want to conclude by a sort of appeal and sharing with you those two informations that in relation to not only the climate change, but the work on health and migration, refugees' health in general, it is time that we start to look to innovative concepts related to health system. Our health system traditionally are developed thinking to the country where the health system is located. So the border of the countries are the limit, and the population within this border is the focus of the health system. We're realizing that that's not insufficient, also because the resources available internationally nowadays for this area are extremely scarce, as you can see from the numbers in the slides. It probably is a time that we need to join forces. So we need to start to introduce concept of I like very much this research we are doing with a tropical institute, London Tropical Institute in UK, the concept of cosmopolitan health system, where the health system, the provision of essential services, particularly for mobile population, is a shared responsibility across border with a pooling of resources, especially in those areas where resources are not available, human or financial. And there are good experiments or good ideas that could lead into that. But what is more important and more difficult to collect is the political commitment. We don't go anywhere if there's no political commitment for a change. And I'm concluding here, there are some of the tools that we put in place in order to assist countries in moving forward in including migration and health into their own national health agenda. This is a tool for policymakers. We call GEM, Global Evidence Review Synthesis Report. We have a health system assessment. So we go to countries and together we are assessing the situation. Thailand was the first one where we pilot still the tool under construction. competency for healthcare workers, because we realized that this was a caveat in the area of competence development of healthcare workers. Research agenda. We need strong evidence in order to support policy making. And there was a huge concern in that area, so we had the first ever research agenda on this topic launched by WHO a few years ago, and now we are having the WIPRO and Euro replication of this agenda at regional level, a number of countries engaging at the national level. And I'm concluding with a tool made for policymakers, for government representatives, for healthcare workers, for researchers, the Global School on Health and Migration. This is a year appointment. This year, we just received the invitation from the Ministry of Health of Spain to run the school in Madrid. And those are global events where we are sharing the latest advancement in terms of public health intersection with migration or refugees' health and migration. Please join in December to the this year's school. Thank you very much for your attention. Happy to get any question, if any.
Thank you so much, Santino, for that outstanding presentation. So just to change things up a bit, Tim and I will have a few questions, just Q&A with Poonam and Santino before we will have our panelists come to the stage. So the first question is for you, Poonam. The audience polling and Santino's presentation, your presentation, highlighted challenges associated with migration. We have political will, financial constraints, coordination being another one. Because migration is such a systems issue, a complex issue, like you said, I'm curious how IOM coordinates across these multilateral agencies across the board of so many migration activities going on.
Thanks for that question, Kelly. Indeed, because it is such a broad agenda, whether you think of it in terms of policy or whether you think of it in terms of programs and implementation, for IOM, it is critical that we work across multiple sectors. Now, we could have a whole dedicated session on how this is done, whether at the global, regional, or country level, but just a few examples in the interest of time. So first and foremost, as I briefly mentioned, IOM now serves as the coordinator and secretariat for the UN network on migration. This is a coordination mechanism that was established after the adoption of the Global Compact for Migration, or GCM, which makes IOM responsible for precisely the sorts of things that you mentioned in your question. Whether through dedicated work streams, for example, on access to services where WHO participates on health, work streams on ethical and fair recruitment where we work with line ministries on labor together with ILO, but also this coordination mechanism is made powerful because it enables us to bring to the table non-governmental actors, civil society groups, private sector, and also multilateral mechanisms, whether for technical assistance or funding, are part of various work streams through this coordination mechanism. Another concrete example I can share is more from the country level, where our teams work very closely within the UN system. So working together as part of the UN coordination mechanisms in country, so that in terms of the migration solutions offered to the host governments, whether the country is dealing with climate-induced displacement, whether there is a disease-related emergency, a public health emergency like an outbreak or a pandemic, we make sure that migration issues, the needs and concerns of mobile populations, data and evidence on population mobility, these sorts of elements are plugged into the country-level coordination and response. This means that also as health professionals within IOM, we are constantly working with non-health professionals. I have some colleagues from Myanmar, from Thailand, from Cox's Bazar here in the room working within IOM programs around the world. And this really means public health in practice, because the solutions to migration health issues often lie outside the health sector, and the coordination at its very core demands that work with non-health sectors to find those solutions. I'll stop there.
Wonderful, thank you.
Well, thank you, Poonam, for that. And I guess the next question, I could throw it out to Santino first and then Poonam as well. I think, Poonam, in your presentation, you used a rather gentle word that there's been a hardening of global response to migrants. Coming from the United States, that's a rather gentle term to call it hardening. The United States, as you know, is a country of immigrants. You know, my grandparents are immigrants, and virtually all non-Native Americans are immigrants. And we have the Statue of Liberty that says, "Send us, you know, your people from around the world." But indeed, we have a very negative migrant view. We see that coming from many countries. I know your agencies can't specifically deal with those, but what would you recommend that we public health professionals do to, I guess, inform policymakers of the realities, given the great wealth inequality of the world, aging societies in rich countries, population growth in poor countries, especially in Africa? There will be tremendous forces pulling people from poor, crowded places to wealthier places that don't have enough labor. How do we inform the world that this is, we need to have a humanitarian, rational way of dealing with migration?
Well, there is certainly an issue of communication, telling the truth, and especially in a moment where the political pendulum move towards anti or pro, we need to stay persistent. We need to walk the talk. And from the public health point of view, we have a huge advantage. If we focus on technical public health dimension, this is able to diffuse political manipulation or political concern. And I'm saying this on the basis of experience, personal experience, where also countries where at a certain point of their history there was a conservative government in terms of vision for migration, still the channel of collaboration was open if our approach, our work was supporting the government to address issues, to try to identify solutions to public health challenges. Then there is an element of persistence, as I say, or keeping, never being tired to share the truth. And one of the most untrue things that is spreading around the world is that migrants, they are moving, or refugees, they are moving, all of them to the northern part of the hemisphere, which is not true. If you take Africa, 84% of migrants and refugees from African countries stay into the region. And indeed, the economic pulling factor is important, the attraction for a better life. But also, we need to explain to public, to society, to media, that these people are contributing to the society. These people are healthcare workers. These people are elderly care. These people are doing jobs which, in many cases, certain society, they don't cover anymore with their own national citizens. And with their own contribution, they're participating to the national taxation system and provision of services. Just a data, a fact, again, in 2008, the financial crisis was so hard, hitting also on European countries, that we've been observing an inverse phenomenon. Migrants leaving European countries and going back. I'm referring, just for an issue of politically correct approach, to my country. I'm Italian by nationality. In my country, large number of migrants moved back to their country of origin, leaving, and those that were regular migrants, means contributing to the taxes, contributing to the social system, leaving behind all those contributions who at the end been benefited from the national, because they stay into the pot of contribution to the national system. We're talking about 5 billion euro left behind by migrants when they return home. So we need to really never be tired to go and explain and to go into details and document what is the reality, because actually the most painful part of our work so far have been the fact that we've been confronting always with a really a manipulated and no realistic picture of the situation.
For all of you in the audience, a takeaway message: it's always a good idea to tell the truth. So it's WHO's official statement. Most of the time. Do you have any further comments on that, Poonam?
Just to add perhaps that, we should, it's usually an occupational hazard for doctors, health professionals, anybody in health adjacent sectors. We are inherently an optimistic crew. So I would simply say that we need, especially the younger public health cadre, those of you who are looking into entering this field. Nowhere is our work more important than when it addresses those who are in need. Many of us here are migrants ourselves, but a lot of us are privileged migrants, even being able to, be in this conference. So I would say that we need to keep that spirit of being able to work together in terms of finding solutions to health issues, and recognizing that often health becomes a trusted entry point, even in contexts of extremely sticky governance issues where health-related actions can actually respond to some of the very hardened policies that, Tim, you picked up on. Health security protects all. It makes borders secure. It enables nationals and migrants to contribute better to economies. So we need to continue to find those creative health policy and operational solutions.
Well, thank you, Poonam, and thank you, Santino. Let's have a round of applause for our two keynotes. And now it's my pleasure to invite our four panelists to join us here on the stage, and then they'll each give a talk. And you guys stay here, please. Santino, Poonam, you get a seat up here on the podium. And then we'll have ample time for questions for all 6 of our speakers at the end of the session. So please come up to the stage. Our first panelist will come up right now, all 4 of you. Our first panelist is Dr. Betty Barca, who's an international development specialist from the South Pacific. She's currently serves as a technical advisor on gender, equality, disability, and social inclusion with Save the Children in the Pacific. Her PhD from Monash University in Australia focused on gendered impacts of climate change mobility in the Pacific, and she was also one of the co-authors of the Pacific Framework for Climate Mobility. So welcome, Betty. Our next speaker will be Otto Chabakuli. Dr. Otto Chabakuli has recently assumed the role of Chief Executive Officer for CIDRS, the Center for Infectious Disease Research in Lusaka, Zambia, one of the leading research institutes in Africa. Dr. Otto has over 30 years of experience in clinical service, teaching, research, and management across public, private, and nonprofit sectors. He has led large-scale programs addressing both communicable and non-communicable diseases, including TB, HIV, nutrition, and NCDs in over 20 countries. The third speaker will be Dr. Pongsak Nityakarun. Dr. Pongsak is Director of the Public Health Administration Division of the Thai Ministry of Public Health. which is responsible for formulating policies and ensuring equitable access to health services for the Thai population, as well as for the large population of migrants here in Thailand. Dr. Pongsak received his MD degree from the Faculty of Medicine, Surirad Hospital at Mahidol University, and he also trained in anesthesiology and critical care medicine in Surirad. So if anybody has a medical problem here, Dr. Pongsak is prepared to take care of you. And our final speaker will Dr. Nian Lin. Dr. Lin is a medical doctor and public health professional from Myanmar, serving as head of programs for Dreamlopments Foundation in Thailand. He oversees two key projects, the Migrant Fund, M-Fund, that we'll hear about today, and C3, a community-based implementation research project of testing and treating persons with hepatitis C. He holds a medical degree from Myanmar and an MPH from France. So we've got these four terrific people that are following our global leaders from IOM and Geneva and WHO. So Betty will start off. Each of our panelists will give us sort of a short 6-minute talk. So please go ahead, Betty. And after the 4 talks by our panelists, we will have an open audience participatory question and answer session for all six. All right, Betty, take it away.
Sounds good. Thank you, team. What an incredible panel, don't you all think? Also, huge thanks to everybody that's sticking around at 4 p.m. on a Friday afternoon. So thank you, everybody that's here. As I've already been introduced, I will keep us moving. I will take you on you've seen the global picture. We've seen what IOM does at a global level, what WHO does on a global level, and regional levels as well. I am going to take you on a very quick carbon neutral journey to the Pacific. In the 5.5 minutes that I have, I will be focusing on a case study, which is drawing from the findings of my PhD, which speaks directly to the gendered impacts of climate mobility, looking at the case of Fiji. This may not look as clear as it should be, but there has been a lot of talk about the Pacific. You would have seen a lot of Pacific delegates across the side events. Just a quick map to show you the various subregions of the Pacific and what I'm talking about, or what we are talking about when we talk about Pacific Island countries and territories. And I do want us to think about everything from the case of a justice lens, not just climate justice, but health justice lens as well, noting that Pacific Islanders are at the front lines of the climate impact on an everyday basis, having contributed almost nothing to the crisis that we're standing up towards. My thesis actually started off with I was a young leader, and we were in a youth camp back in the Pacific, and there was a colleague from the Marshall Islands who actually stood in front of the room and begged the entire room of 100 young people for sand because his island flooded when king tides came. And I was 18 years old, and that inspired my journey into climate activism and academia and international development and so on. But the reality is that rising king tides is just one of the many things that happens across the region. In Fiji, for instance, we are moving entire villages. At the time of doing my PhD, there were 7 entire villages that were either going to be fully relocated or partially relocated because they would not be able to withstand the impacts of climate change. That included rising sea levels, but also flooding because of landslides or salination and so much more. There were various things. Of course, I need slides to keep me on track because my PhD was 3.5 years of work and this is only 6. So there were gendered barriers in relocation decision-making. In Fiji, the planned relocation component was state-led because of various resource capacities. But the villages did subsidize it with labor and resources from their farmland. For example, timber was provided for the new homes from the land of the villages. it was also recognizing that poor planning creates long-term health and livelihood impacts. One of the first cases of the villages that was ever relocated in Fiji is now being used as an example of what we should not be doing when we're relocating people. For example, there were homes built without doors in the bathrooms, or entire homes built without kitchens because they ran short of materials towards the end. But we needed to do that to know what to do differently and to know what to do better. Women were naturally excluded from the decision-making because of various sociocultural norms that exist within communities. And that, for instance, includes when we go into communities for consultations, it is often with community leaders. Who are our community leaders? I need not say. Even when there were provisions to have gender segregated consultations by the state, women did show up but didn't know what we were talking about. So you can have all of these consultations and you can do all of those things that are on the checklist, but if you're not doing it in a meaningful way where people are spoken to in languages that they feel comfortable in, with people that they feel comfortable in, it sort of does not serve the purpose. There was also examples where young women who had just been married into these communities wouldn't attend these events because they didn't feel like they belonged, and they didn't feel like it was their place to voice an opinion. So there were various things that kept coming up. And that speaks to the intersectional experiences of people when we're talking about relocation. An assessment by the World Bank has estimated a few years ago that 80 communities will need to be relocated across Fiji in the next 10 years to avoid dire. And this is a comprehensive vulnerability assessment that was done a few years ago. Moving on to some things that are being done. And fortunately, one of the wins from my PhD is the findings, and some of the language has contributed to the Pacific Regional Framework on Climate Mobility, as you can see. So it does take into account the intersectional needs on paper. And it is a very new framework. So as of 2 weeks ago, the governments of Fiji and Palau are actually having a learning exchange on what to do and what not to do when you're relocating entire communities of people. There were 3 things that were very clear when I was working alongside IOM in developing this with a small team of researchers from University of New South Wales. One thing was clear: people wanted to stay in place. It was absolutely the last resort. Movement options were very limited. It was not like there were choices. There was only so much you can do across islands. The displacement responses were often evacuation centers in schools or church halls, which already were quite exclusive to people with impairments and gender non-binary people who felt unsafe in places where they were used to celebrate but could not feel safe during times of disasters. I know I'm running out of time, but just to say that the Pacific Regional Framework is a step in the right direction globally, because it's one of the few regional frameworks that actually recognizes the complexities of the health and the climate crisis. It's an opportunity to bring these together and work towards a shared goal. It is also an opportunity for us to reset and regenerate. There is so much evidence right now for us to work, improve, and strengthen systems that address all of this. I did want to speak specifically to solidarity dividend, because there's increasing thinking that, when people move into a particular place, a new place, mostly within country or across borders, that you're going to lose out on something. And I think it's very important that we get rid of, try to combat this notion that if more people are coming, it's going to mean less resources for you. And that is sort of something we're trying to address through the concept of solidarity dividend, which was coined by Heather McGee in a book. And I do think it is an opportunity for us to regenerate power and understand where power truly lies and make sure that it's equitable and resourced, because we now more than ever, we actually have the resources to address it better. That is a very brief summary, so thank you, everybody. If you have questions, I'll take them afterwards, but thank you. That was the quickest journey to Fiji I could take you on. Thanks, everybody.
Thank you, Betty. That was really terrific. I wish you had an hour to talk to us about this, but we have to move on. So the next voice is from Africa, a colleague and friend, Dr. Otto Chabakuli.
Thank you very much, team. I would like to start by thanking PMAC for organizing and convening this discussion at this point in time. It is really timely. Since the beginning of the conference, we heard about the macro level. Mine will be just an attempt to give you a little snippet of what is happening on the ground. The polycrises that are known to drive population movements are prevalent in 28 of the 49 sub-Saharan African countries. And these include food insecurities that ranges from IPC phase 3 to phase 5, but also ongoing armed conflicts in the Sahel, Central Africa, and the Horn of Africa. The picture that you see right now, it is not a picture that started like 6 months ago. This has been ongoing for quite some time, decades. And these conditions are likely to intensify in the decades to come. Why? Because of climate change, but also the current geopolitical realignments are likely to breed more conflict. Like we heard this morning, about 80% of people who are displaced forcibly, they don't make it to Europe or America. So when you hear in the global media about migration, it's probably about the 10 or 20% of those who make it. Now imagine about what should South Africa feel like? Nigeria, Uganda, these neighboring countries that actually host the 80% of those who are migrating. So they settling primarily in neighboring countries. And this reality, and especially its implication for destination country health systems, we don't talk hardly enough about it. When you have so large a number of people coming in and attending and utilizing your services, social services, definitely there are some implications for your own planning and resource allocation. Now, at one point, we thought that displacement was just a temporary thing. People will move and come back home. It's no longer the case. Displacement, the average period of displacement right now is about 20 years. And that fact alone, it requires us to have a shift in our mindset. People are displaced, especially in the camps. The conditions of living are really difficult. And imagine spending 20 years in situations like this. So we'll have, even as we think about humanitarian aid and interventions, we'll have to move away from just the emergency responses. We have to start thinking about systems, long-term interventions. Now, just 2 weeks ago, the Africa CDC Epidemic Intelligence Report highlighted 8 events, including cholera, measles, mpox, and dengue fever. And these 8 events that they've highlighted is part of 40 that are currently ongoing on the continent. These epidemic outbreaks, they are occurring in countries whose health systems are already under severe strain. For example, primary healthcare coverage in much of sub-Saharan Africa remains below 60%. The per capita health expenditure is far below the global average, and chronic shortages of health workers persist. Now, in this context of resource scarcity, it is not surprising that tensions will emerge between host communities and the migrants. And that is going to prompt politicians to adopt exclusionary policies because you want to service your people first. There's a global tendency to blame the poor status of basic health services on migrants, like Tim alluded to earlier on. In Southern Africa, we call that medical xenophobia. But the critical point remains this. Migration does not cause health system fragility, it just exposes it. Now, exclusionary policies, they will not eliminate the high demand for health services. Instead, what they do, they drive migrants to delay seeking care. They present often at emergency level with advanced disease, and all of that is costly. So ultimately, the long-term cost increases and outcome are worse if we adopt exclusionary policy. Now, when migrants are excluded, there are three things that will happen that I just want to highlight. The first one is that their children will not get vaccinated. Please note that sub-Saharan Africa accounts for 60% of the global zero-dose children. Secondly, the detection of infectious diseases such as TB and HIV becomes difficult, it's delayed. And lastly, infectious disease outbreaks become harder to control. So cross-border health threats like Ebola, Mpox, and HIV will be amplified by mobility, not because migrants are at risk, but because the current systems are not designed to handle it. Now, for all these reasons, it is important to advocate for migrant-inclusive health systems in Africa that will enable early detection of diseases and of epidemic potential and timely and equitable response. And for that, we need to invest in primary health care, community systems of care, and mobility-sensitive disease surveillance. Now, the response to COVID-19 pandemic and HIV has amply demonstrated that we have resources in our communities. And when need arose, we mobilized community health workers, and they were at the forefront of controlling these particular threats. Now, the current advances in digital technology, we should take that as an opportunity for efficiency and significant cost savings, be it through adoption of telemedicine or digital health or mobile health records. The results will be promising. Now, cross-border data sharing is not optional. It will be essential for early warning, preparedness, and a coordinated regional response. Now, in closing, let's also acknowledge that intra-African migration is not a temporary crisis. That will be the first observation. It is a structural feature of the continent's future. It is here to stay. Now, the current health systems were designed for static populations, and they're inadequate to cope with what is happening and what will happen. So if we do not change and adapt and reimagine health systems, the current health system will continue to underperform. So I hope that from this meeting, we'll have solutions to this problem. Thank you very much.
Well, thank you, Otto, for a very powerful series of messages in a very short presentation. And hopefully we can get you back to PMAC to tell us more about that next year, because there was a lot packed into your talk. So our next two speakers are from Thailand. And first we're going to hear from Dr. Pongsak, representing the Ministry of Public Health in Thailand. And then we'll be hearing from Dr. Lin, who works for a not-profit foundation. So you'll see, I hope, from these presentations, one of the great characteristics of Thailand, which is to have things work together. And I think it's a great example of a 1 + 1 = 3 situation. And we'll first hear from Dr. Pongsak. Thank you.
Thank you. I'm honored to present you to an overview of migrant healthcare in Thailand, a topic that reflects our commitment to inclusive, equitable, and sustainable health system in a very short time, 6 minutes. Let's go. Okay. Thailand has long recognized the importance of protecting the health of all people within borders, including migrants. Our national policy emphasizes 4 key pillars. First, the inclusion of migrants in universal health coverage. I think that it is the strongest key feature in Thailand. And the second, the development of migrant health volunteer, also the very strong factor for Thailand too, or MHV, who serve as cultural and linguistic bridges. Third, a strong focus on health promotion, disease prevention and control, and finally, collaboration across ministry, sector, and border to ensure no one is left behind. To understand our approach, let's first look about Thailand health financing landscape. We have the 3 main public health insurance scheme. First, the universal coverage scheme covering 47 million people. The social health insurance scheme, which covers 12 million people. And the last one is civil servants medical benefit scheme that covers about 5.1 million people. And also we have the private insurance too. From you see from the slide, Thailand spend about 5.16% of GDP on health. Its schemes of the financial scheme it has show its own administrative body, funding source, and payment method. The UCS is tax fund and managed by the National Health Security Office. The HIS managed by Social Security Office, and CSMBS for the government officer under the Ministry of Finance, youth fee for service and allow balance billing. This picture show about healthcare delivery system to understand to the migrant health system. You see that Thailand have can deliver system in tier and public dominate. We are public hospital dominate. At the top, we have the provincial and regional hospital offering tertiary and secondary care for a population about 600,000. At the district level, we have district level and sub-district level hospital. At the grassroots health center serve sub-district with population as small as 2,000 people. These centers are staffed by nurse and paramedic and supported by village health volunteer who act as gatekeeper and community liaison. And now we have go to the healthcare for non-Thai to have developed several schemes to extend coverage to migrants. First, Social Security scheme cover about 1 million legally employed migrants. And the next is the Migrant Health Insurance Scheme, MHIS, and compulsory migrant health insurance. I will explain you to the next slide. What is compulsory? Of cover around 600,000 migrants, especially those work permits. And some migrants also access private insurance, often to employer. And for the most vulnerable, the M-Funds, non-profit initiative, offer affordable coverage to undocumented and underserved migrants, especially in the border area. Health service access, you see that the health service access, I think that is very important to the migrant worker. They can access at the public or the public hospital that they register for the hospital. SSS member access can through designated hospital via their employer. MSS member pay an annual premium and use assigned facility. M-Fund member enroll directly and receive community-based support. Importantly, public hospitals are mandated to provide emergency care to all, regardless of legal status. This ensures that no one is denied life-saving treatment in Thailand. And MHIS and CSMH compulsory migrant health insurance means that the migrant with work permits waiting for social security scheme, and migrant health insurance also will include Cambodia, Vietnam, Laos, and Myanmar. And dependent of worker age under 7 years, you have so many schemes, so many budgets that make it suitable for who want for who have a low budget for the worker, for the migrant. Cover service for health promotion and disease prevention. You see that we provide using personal health record book for continuous health care. We have also give them a prenatal care and postpartum care for pregnant women, health checkup, administration of antiretroviral drug, also family planning, home visits and home health care service, health education, counseling to promote health, oral health promotion and disease prevention and control. Migrant health volunteer, a cornerstone of our approach is the migrant health volunteer. MHV are migrants themselves trained to provide basic health and education and support. They help overcome language and cultural barrier, build trust, and connect community to formal health services. To date, we have over 4,000 MHV have been trained across the country. Thailand approach as a model that we include universal health coverage to all people who live in Thailand, and we are include in partnership and collaboration across sector, and the vital role of migrant health volunteer and a commitment to gradual progress and continuous learning. This model has gained international recognition and offer reason for other countries. Strategy for improvement. Looking ahead, we aim to strengthen the implementation of existing policy, expand the role of MHV to outreach and education, address language and cultural barrier to training and integration, collaboration with destination country to ensure continuity of care and share responsibility. And now is the last slide, okay? Closing message. Let me close with a simple but powerful reminder. No one is safe until everyone is safe. Health security is shared responsibility. By protecting the health of the migrant, we protect the health of all people in Thailand too. Thank you for your attention.
Dr. Pongsak, thank you. You covered a lot of material in exactly 7 minutes, so thank you. We're very much on time here. Everyone's been very, very attentive to the guidelines. So what you're going to see here is really, I think, unique to Thailand. What you just saw is Thailand's very comprehensive, very compassionate, but if you step back from the reality, it's good for Thailand. Thailand is far below replacement with its fertility rate now. It would have a shrinking population without migrants, and they have turmoil on virtually all the borders of Thailand. So this very progressive, compassionate, but sensible way of dealing with migrant health in Thailand is really exemplary. So thank you for that. And now we're going to hear from a not-for-profit foundation. Dr. Nien Lin will talk to us about the M Fund.
Thank you, Tim and Kelly, and also to PMAC for this opportunity to present ANFUN. So we heard about the global situation and then regional situation and different country contexts. Now I bring you closer to the Thai border where we implement the Migrant Fund for undocumented migrants. So this is the context that we are all aware of. So Thailand has millions of migrant workers from neighboring country, and Dr. Somsak has presented about the different migrant health schemes. So there are government health insurances are in place for migrant. Actually, there are two schemes, Social Security Scheme and Migrant Health Insurance Scheme. But as you see in the previous slide, section, it's tied to the designated hospital. So if you're working in a certain provinces, and if you move to another location, and then it's challenging for you to come back to the designated hospital. So for that reason, many registered migrants are still uncovered. And then there's another story of unregistered migrant. So estimated is 1 million, but who knows how much. So this give us a clear example that even in a country like Thailand, with the comprehensive UAC for its own citizen, strong commitment, strong ambition, and migrants are still falling through the cracks. So that's where ANFUN comes in. So DLP, Dream Development, we set up ANFUN as a low cost, meaning affordable, not-for-profit health access fund for those who are not covered by any of the government insurance schemes. So ANFUN creates a mechanism where the migrants can participate. They can self-establish their own risk pooling where they can use health services whenever they need it. Our vision is to extend ANFUN to other countries, but right now we are largely based in Thailand and we operate in the neighboring countries. So how does it work? So we have a team of community workers who are full-time employers. So they themselves are from the migrant community. So they know the area, so they promote the project, they explain the importance of the health protection, even if they are healthy. And if they're interested individual, they can be enrolled easily through the ANFUN digital application. We provide them with a tablet, and so they can take picture, take the basic information, and enroll. And the potential members, they have to answer the simple structure questionnaire and sign the agreement form. And then afterwards, they can pay monthly to maintain their membership. And more than 90% of our members can only pay in cash because they don't have document to open bank account. And each member will receive a digital membership card tied to the physical QR card. It's quite small, but that QR card is important because whenever you need healthcare, you have to bring that card to the partner hospital. And the partner hospital, the staff know about ANFUN, so they scan it, and they will see the digital membership card, as you can see here on the right-hand side. And the first thing they look at is on the top right corner, you can see the green active status, means that their membership is active. And then the next thing they look at is the outpatient, inpatient, how many times they have visited, what are the ceiling remaining. And if the membership are active, the member, they don't have to pay anything at the hospital. Because at the end of the month, the partner hospital send the bill directly to us. And we have a team of the medical officer verify all the detail. and we transfer the payment back to the hospital within 2 weeks. So this is the implementation at a glance. So we are now operating in the 8 border provinces in Thailand, and we have a small team each in Myawaddy, Myanmar, and Phoi Phet, Cambodia. And you will see some of the green area where we don't have offices or physical team on the ground, but there are some individuals who are interested and who want to enroll, and we let them enroll through online. But the only difference is since we don't have any partner hospital, when they go to any hospital, they have to pay upfront and they can request reimbursement later. So up today, we have over 100,000 members voluntarily enrolled into our system, and we are working with over 250 partner hospitals across the border provinces, and ANFAN has been able to cover 180,000 outpatient and 22,000 inpatient medical events from our member. So here comes a little bit of the gender dimension. So we found out that 70% of the service users are female, and 1 out of 4 were pregnant when they use services. So it highlights the importance of the reproductive health and MCA services among the migrant population. So these are the some photos that highlights that we got support from the different health authorities. We signed MOU with some of the provincial health offices, and in some area, we work directly with the individual district and provincial level hospital. So this slide highlights the increased recognition and acknowledgement that ANFAN received from the government counterpart. So this is the launching event of the National Migrant Health Working Group back in 2024. And on the left-hand side, you will see Dr. Subhakit Sarilak. Actually, he is the one who gave green light to initiate ANFAN in Tak province 9 years ago. Now he is a director of the Health System Research Institute. And on the right-hand side is Dr. Surachok, who is currently the Deputy Permanent Secretary of the Ministry of Public Health. So both of them included ANFAN as one of the schemes that helped cover the UAC in Thailand. This is probably my favorite slide because this highlights the key activities that our community workers are doing. So I would like to take this moment to give a huge shout out to our team in the ground because they work day in, day out, rain or shine. And you will see in the middle picture, that's how they collect the monthly renewal fees from our members. They go directly to the houses of the members and they collect the money in cash. And every transaction is captured in the ANFAN application. So here's the key messages that I would leave you. So ANFAN, which is a community-based, flexible, affordable model, which is proven to be effective. And we are not competing or we are not running in parallel. We are working in the same system. So we show the effective collaboration with the provincial health offices and also the existing health system. We are not going outside. And also ANFAN is preventing the catastrophic cost of care. So we reduce the economic vulnerability. So we cannot prevent the climate stresses of climate change. But whenever there's a climate stresses, we reduce one layer of vulnerability. We help in the recovery from the shocks. So over a decade, almost a decade of implementation, we have a lot of evidence and we keep advocating. We keep giving inputs to any migrant-related forum and conference like this one. So I will look forward to the discussion. This is the end of my slide. So I'd like to give the acknowledgement to the current funding partner, which is important. And thank you so much for your attention. Kap.
Wow, Dr. Lim, thank you. That was a terrific presentation. And let's give a round of applause to our 2 keynote and 4 panel speakers. So we're delighted that you're all here, and I hope you share in my kind of amazement of what we've heard in the last hour and a half. Unfortunately, we've got about 30 minutes now, so we have ample time. We would very much like to have audience participation. So my co-moderator Kelly is going to help handle the questions from the field, but please see Kelly or come to one of the microphones, and the floor is open to questions from the field.
Thank you so much. Mariko Sato, former IOM, and so obviously the subject was really, really interesting. Thank you. Congratulations to Thailand for this UHC, despite the gap, and then you have a complementary partners, which is great. Santino, I have a question to you. Listen to me, right? You mentioned in your statement, it's not the UHC doesn't include migrants and refugees. Thailand has included. Universality, we're talking about universality. It's not at all universal. So it is un-universal health coverage, isn't it? When the governments are moving the hard lines, how can we, so going through the UHC national state-nation system is limited. In this environment, global environment, how can we ensure that the inclusive, true universal health coverage, including migrants and refugees? And the Fiji presentation, putting my UN Habitat hat, I recommend highly the People's Process for Settlement Recovery. There's excellent guidelines where the people are the housing drivers in rebuilding. So I can share the publication with you. So thank you so much. 감사합니다.
Thank you. No, very briefly, no, I fully agree. And Thailand is recognized, we call it champion country. We are observing and been working with Thailand since long, exactly because of the special attention and the pragmatism of the country showing this area. Indeed, the situation is changing worldwide. I was a bit fast in the presentation because of the interest of time, but we have a dashboard which is showing that about a third, a little bit more than a third of the member states worldwide, they are moving towards de facto a universalistic approach, including migrants and refugees. As the colleagues just mentioned, that this doesn't mean that on the practical point of view, things are sorted out. There are always cracks, there are always peculiarities which make things difficult or showing us that the situation is not ideal. How to move forward? In my experience, having a privileged observatory, because I see and I can compare different country reality, countries where really we are observing a paradigm shift in terms of approach or really a committed implementation of universal health coverage are those countries where something happened at the political level. So there was a political commitment that for a number of reasons, and this is very specific country to country, which is trigger the cascade of actions, policy, services, healthcare workers, monitoring, data, so all what is needed to have an health system which is including refugees and migrants. This is a major step forward if we compare with a few years ago where the issue was nominal. We were, from the advocacy point of view, all agreed that this was supposed to happen, but de facto nothing was, or not much was concretely happening. You have seen also the presentation from Africa, and I was very happy to hear and to see synergy with what I said before. The situation, especially for the complex financial situation worldwide, it is time that we look into innovative approach. So where we have strength, capacity, political commitment, we need to look at those countries, we need to look at their leadership in order to promote innovative health system approach, which is not focusing only on the population within the country, but also really looking into inter-country collaboration in order to fill some of the cracks we are observing. I think the next one was for you.
Sure, I think that was a comment, and it's very welcome. But also to note that most Pacific Islands are developing their own planned relocation guidelines or displacement guidelines, which draws heavily from global tools and guidelines. So absolutely a huge portfolio of work that is, in all essence, still beginning, right? So, yeah, thank you.
Yes.
Thank you.
First
for the
microphone.
presentations. And
Professor Razak.
This is a question to Dr. Nyan Lin. Thank you so much for presenting that very wonderful program. The question is, in terms of, Yatu Razak, Faculty of Medicine, Chulalongkorn University. And the question is, you have done a great job, and there are so many migrant workers as well as displaced population of Myanmar in Thailand. And so what are the main challenges to expand your coverage, and how other institutions can assist you in expanding the coverage? So that comes to the point is the satisfaction of the people who enroll in your system. And so to expand it, they need to feel that it is useful and good. And I'm sure that is very good. And so I'd like to get a little bit of an idea of that one. And the third question is about the 250 hospitals and clinics providing the services. Some of the challenges are language and cultural barriers. So how do you work with those hospitals and clinics in terms of overcoming those barriers so that services which they are providing can be better? So thank you.
Thank you for the question. Let me reiterate what you asked. So the first question is with regards to the expansion and increased coverage, while the second question is related to member satisfaction. And the third question is working with the 250 hospital, how do we manage the different barriers, including the language? So to answer the question, for the first question about the expansion. So now we are working in the 8 provinces, but actually we have project offices in 6 only. And in 2 provinces, we have a team of community workers. So what ANFAN does actually is to facilitate their access to the public hospital. So for example, the largest group of members are residing in Tak. So Tak is a province where we have Mesot city, and on the other side is Myawaddy in Myanmar. There's a lot of cross-border movement, displacement as well. So in those areas with the big migrant community, we focus on the service provision and to make sure that the management is complete. But when it comes to expansion, we have to be very careful because we have to first look at the area, the density of the migrant, the concentration, so we have to do the field assessment as well. And the second thing is we have to identify the partner to work with. And as I mentioned in my slides, most of our partners are public hospital. So we work within the public health system. So we have to navigate the mindset, the attitude, the response from the local health authority as well. So this is another crucial point. And thirdly is the cost. I mean, every project has an operation cost. And we've been lucky that we weren't affected by the USAID cut. But anyway, the ripple effect is obvious. So we have to make sure that our operations are efficient, and we have to make sure it's cost effective as well. So these are the 3 points that we have to carefully review before we do the expansion. And for the member satisfaction, actually we are conducting our first member satisfaction survey last December. So we completed the collecting responses and we will start analyzing. But we do have other activities to identify the member satisfaction. It's a QA, quality assurance visit. So we did it once in a year in every project site. So what we gather from our quality assurance finding is that most of our members are satisfied with the first contribution fees, which is affordable to them. And second is the coverage. So 50,000, that's a lot for the migrant, it's a safety net. But the third part is that when they go and access care at the partner hospital, there are variation in responses. Because we do not intervene with our partner hospital when they provide services, because that's according to the Thai public health system. And we give them full autonomy in deciding treatment, diagnosis, and everything. And since we are working with the public hospital, every quality assurance and everything is under the Ministry of Public Health. And so working with the hospital, language barrier obviously come up on top, but we are trying to solve in a certain area because we cannot have our staff in all the 250 places. So for example, as I mentioned earlier, in Mesot General Hospital, where we have like every day 40 to 50 members visiting the hospital. So we do have a small corner in the hospital. And we work with the hospital authority. So we have a corner where we have our staff within the office hour, and they can help navigate the member if they get lost, if they need to translate, so things like that.
Hello. Let me explain more detail about the Thai public hospital. In every Thai public hospital along the border, we have the center for the migrant who contact, not only for the M fund, but for another fund for all, another private insurance as well. We have the center, and the Thai Public Health Ministry have the project to have the translator for the hospital that near the border, and we have the project to have improve the migrant health, and we have the people, the health professional who dedicate to about this issue. Okay, in every hospital along the border.
Any other responses from the panel here for that? If not, we'll move on to the next question.
Thanks to you all for such an engaging session. My name is Adam Richards from Johns Hopkins University Center for Humanitarian Health, and also here in Maidal. The first session this morning, when they had the bubble, had the keywords and everything, the biggest one, and in fact the runner-up, was equity and equitable. My question is, maybe to all of you, what would you recommend in terms of how do we actually capture vulnerability in people who have left all their belongings behind and have moved on? A key feature of humanitarian response, and I think a lot of health systems try to make sure that they're reaching the most vulnerable, but how do we know who they are? We've heard from a lot of people, oh, if you don't measure it, then there's no action, there's no accountability. Conducting workshops with humanitarian health researchers, this is an open question, and I would value your experience. Food insecurity in particular tends to be an indicator that something is horribly wrong, and it is associated with every other bad health outcome and health utilization. But you might have less wealth, but there's still a variation in what people own. Some people are able to earn an income. Some people have registration status. Can we combine all of these into a multi-dimensional, measure of vulnerability? And are you interested in joining me in that project? So thanks.
I'm trying to could you perhaps distill your question down as something that...
How do you measure vulnerability among forced migrants in particular, but any migrants? Thank you.
All right. Yeah. I think our IOM colleague has this nailed. Go take one.
I'll just start with a few reflections, and thank you for the open solicitation of partners. I'm sure there'll be interest in the room. It's a very complex question you ask, so of course there isn't just a single answer. But vulnerability, when we look at forced displacement, whether internal or across borders, has many different variables to consider. And to begin with, even whether it's internal displacement, which means individuals are moving within borders and may have legal identity where they are moving. They may have access to certain public services, should those services still be standing. It depends on the context in which the displacement is occurring. Versus if they are moving across borders, when we think of forced displacement. So I would say that there isn't one universal answer to the question in terms of who are the most vulnerable in forced displacement contexts. And your center has done some outstanding work in both acute and protracted conflicts. I remember the teams in Afghanistan from way back when. I understand also more recently in Syria with the changing context. So it's really, in our work at least, where we are present in these contexts, we tend to work locally. So there may be a whole gamut of indicators or variables one can look at theoretically, but it really depends upon the local contexts in terms of are they in an area where, infrastructure still stands? Are we talking about water, sanitation, hygiene? Are those basic indicators met? And then the profiles of the population. So it's really a very multifaceted approach. And and often, admittedly, our programs, our responses, our work with partners cannot really address all of them in one go.
Dr. Chabakuli would like to answer that question as well. Thank you, Otto.
Yeah, that's a great question. It reminds me of an experience. I think in most vulnerability measurement, we'll try to look at some physical assets, but I think the biggest indicator of vulnerability will be isolation, because when you are on the move, what may keep you alive is the people around you or your social network, and that usually is not taken into consideration. It reminds me of an experience in the Eastern DRC where we wanted to send money to people we categorize as vulnerable, like children and so on, but we spoke to religious leaders, and they told us that there are some elderly people who couldn't make their 40 miles on foot, and they are left by themselves to fend for themselves in their homes. And those are the most vulnerable. And we had to reallocate those resources to them, because some of the younger ones, they have those kind of networks that they can still manage to survive. But these ones are way much more vulnerable in the same environment.
Otto, go ahead. Yeah, we'll get to this question. I just wanted to follow up on the Otto, because you were talking about the migrant situation in Africa, which is quite profound. What's the level of discussion in the African continent about the dynamics of migration and migration health and vulnerability?
I think it is discussed. It is discussed in every country, but because there are so many priorities that the countries have to face, it always falls a little bit behind, even within countries that are affected. Let's say the ones that I'm very familiar with is the Eastern DRC. That's a country that has a need of almost everything. And the politicians obviously will want to look at their political situation. They want to win elections, remain in power, and they will tend to think about the humanitarian situation as somebody else's problem. The UN will come, the Red Cross will come, Médecins Sans Frontières will come, and you remove that from your list of priorities. It's not on your agenda because there is foreign aid that will come to take care of it. And that has proven over time to become a very, very big mistake, that countries are not taking into consideration the particular issue of migrants, like in Thailand, as part of their own domestic agenda.
Yeah, good. Santino.
This is absolutely true. And although I like to compliment that we are observing a slow change, we are experiencing African countries really willing to move towards universalistic approach, and namely Uganda, Kenya, South Africa, where the issue is brought up. And for me, it was quite impressive to see at the last World Health Assembly, Burundi, in the name of the 47 African countries, asking WHO to do more on this area, to support them on health and migration. So we see somehow a growing attention. Also, the African Union plays health and migration as one of the priority of the African Union. So it's quite interesting that we are observing a changing approach, a changing attitude.
Well, thank you. And I guess that just highlights the vulnerability of all the populations and the recent geopolitical transitions in the world. And I'm an American, the United States pulling out of WHO will weaken the ability to react to that. So it really is going to weaken the global safety net for vulnerable populations, for sure. The next question.
So good afternoon. My My name's Joseph Lachica. I'm from the Philippine Health Insurance Corporation. It's from the Philippines. So from the Philippines, we have a lot of Filipinos working abroad. And we generally talked about migration from a general perspective and from a bit from the perspective of a host country. I want to flip that perspective that I asked about the perspective from a country sending out migrants, knowing that they still have ties at home. So what are the options that the country can pursue to ensure the health and well-being of their citizens, their migrants in different countries, especially the ones that are in the vulnerable ones, which mostly are in the informal employment. Thank you.
Who wants to take that?
Let me react at least to the fact that the Filipino situation is actually extraordinary. And we've been asking to the government supposed to document the work they're doing and sharing worldwide, because I think it's the only reality where country of origin, sending countries actually as a strategy, as a number of services to support their own migrant population. It's a pretty unique situation. I've seen something, but much smaller scale with Mexico in a moment, particularly in the US, with service offer into the embassies. But what Philippines does is really unique. It should be documented, shared as an opportunity for cross-learning.
Seconding, of course, what Santino said, and so you're from PhilHealth. It's indeed a model that we should be emulating and also using in capacity development discussions as one idea. So you, in some ways, have an answer to the question you pose to the panel. So, of course, the unique feature, for instance, of portability of health insurance, where you have a system for emigrating workers to be able to contribute and still have entitlements despite their mobility. The model of having services available in consulates in countries that are destination countries for the migrants is also an excellent one, where you can precisely overcome the sorts of cultural, language, communication barriers. And another model which not only the Philippines but also other countries in ASEAN and increasingly SAARC have been following, for having bilateral labor agreements whereby there can be policy level agreements made between sending and destination countries, bringing in not only the public sector but increasingly the private employers. And I would say that is one area where all of us, including agencies like IOM and governments, can do more, where we need to bring in the private sector partners more in order to show them through hard evidence how promoting the social safety net can actually be a win-win solution in contributing to their economies, keeping health security, safe borders, but then also contributing to the sending countries. And lastly, another area where we see gaps and more needs to be done is cross-departmental or cross-ministerial collaboration in source countries. I know the Philippines has had an interministerial coordination mechanism for migration health. I had the honor and privilege of being in Manila from 2010 to 15 and actively working with DOH on the same. But I also know from the Philippines, but also other countries, that often what the Ministry of Labor or Finance may be doing may not be shared with what the Ministry of Health or other sectors may be proposing. So, and this is an open question, how we can better support each other in bridging that coordination, even within the same government, to be at the table stronger with civil society groups, with private sector and others. Thank you for your question.
Thank you so much, Poonam. We have time for the one last question at the microphone.
Thank you very much. My name is Yuka Uchita. I am Senior Specialist on Occupational Health and Safety from the ILO.
Nice to see you.
I have a question regarding the M fund. Especially, I'm interested in the coverage of the occupational injury and disease. I assume many of your members are workers, and they also assume some workers are registered. So it should be covered by SSO. But the challenge is it is very difficult to diagnose or to judge this is the occupational or the work-related or the outside of the workplace. So my question is, do you have any capacity to judge or to diagnose this is work-related? And if it is work-related, how do you coordinate between your fund and the SSO? And my third question is, what if you have any prevention action? Of course, prevention pay more instead of the pay for the treatment. So if you have any activities of prevention, please share. Thank you.
Thank you for the question. So for the first one is the work-related condition, and if they are under social security scheme, how do we avoid the overlapping? So from the very beginning, when we explain about ANFAN and if they are interested or not, and our community workers, they always ask that, are you registered or not? So if they are registered migrant, and if they are under the social security scheme, we will not let them enroll into ANFAN because they are covered by the social security scheme. And with regards to the work-related injury or diseases, as I mentioned earlier, we gave full autonomy to the hospital. So we do not judge their clinical decision or management. And all of the criteria from the Thai health system, I believe, is ICD-10. So they have a criteria to categorize the different diseases. But there's one particular example. So for those who are registered, who have a registered motorbike, so there is a motorbike insurance in Thai. So it's about 30,000 Thai baht. So for example, if I have a road traffic injury, and if I have a license, if my motorbike is registered, and then I can claim from the different department, the 30,000 would be covered. So if they have that, they use that coverage first. But sometimes the road traffic injury, I mean, if you have a fracture, and so it can cost 50,000, 60,000. So on top of the motorcycle insurance, so ANFAN gave a secondary layer of the protection. So that's how we work in the practical setting. And for the second question about the prevention, so our community workers, they are from the migrant community, and we give them the refresher training every 1 or 2 years to refresh about our ANFAN application, because as our ANFAN is right now 5.0 plan. We've evolved a lot over the last 9 years, so 1.0 to right now 5.0. So every time we reformulate our scheme, we give them the refresher training. And in that training, we try to integrate a basic concept of the health program. For example, reproductive health, family planning and contraception, basic concept of TB, malaria, HIV. So we give them that, but this is not their priority to do the health education, but whenever they see the case that's related to this condition, they provide the health education informally. Yeah.
Great. Wonderful. What a great discussion we've had. So Kelly, you're up next. We're going to go back to Menti. Remember, we asked a couple of questions at the beginning of the session. So before we thank and wrap up the panel here, we're going to do 2 Menti questions, I think.
Yes, thank you, Tim. So we have some time to have a few Mentimeter questions. If you could, again, scan the QR code or go to menti.com and use the code 83163787. Great. I see a lot of folks are already on here. Okay, we see a shift in numbers. So initially we had around 7 or 8 people who weren't optimistic. And now we have a lot, the vast majority is somewhat optimistic about the future of global migrant health equity. So our panel did an excellent job to make people more hopeful. Awesome.
Menti's a little bit slow up on the
Let's wait. True. We can keep this up for a few more seconds.
I'm an epidemiologist, and I declare that somewhat optimistic is the way the audience feels here.
Okay.
Let's go to the next one.
Great. And if we could go to the next one, same question. Same question as the beginning. What do you think about the future of migrant health in 5 to 10 years? Much worse, the same, better, or much better?
We have a somewhat optimistic audience here,
Yes.
which is fantastic. Huh? Yeah. Well, that's a very optimistic outcome. Fantastic. The future of migrant health, even though we know the burden of disease issues and the size of the migrant population is undoubtedly going to expand as we see income distributions, income equality get worse, and large population growths in some countries where we're going to see that. So here's the last question.
The last question, if I could enact one systems change for migrant communities, it would be. So this is your opportunity based on what you've heard from the panelists and the keynote speakers. We have getting political commitment, inclusive health systems, more primary health care, and more trained staff. a lot of votes for Thailand. Equity regardless of nationality, integration into host community, M-Fund in more countries. Great. This is, I think, a very, very successful session. So I'll pass it back to Tim for closing remarks. Thank you.
Well, thank you, Kelly, for that. I love the mentees, and it's always nice to take the pulse of the audience. But first of all, I want to thank our 6 speakers here. We heard from the experts from Geneva, from IOM and WHO, very authoritatively describing how those 2 UN agencies organize themselves to take on a broad mandate and role around the world and helping countries deal with these issues. So thank you for that. And then I was very pleased we had 4 speakers representing Fiji and hearing about communities getting literally washed away, leading to moves. We heard from Otto Chabakuli about, and that could have been a whole week-long session talking about health challenges in Africa and the migrant situation. So Otto, I'd like you to book next week, and we'll have, next year we'll have a day for Africa to address health challenges in Africa because they deserve it. And then Dr. Nitkun and Dr. Lin to really give us a very special reality that Thailand really has a wonderful health system. Of course, Thailand, very famous for universal health coverage, and that's been expanded and extended quite generously to people who are migrants for health care. And then the M-Fund, which is a very innovative organization or a project that fills in the gaps for this. And I think all of these serve as wonderful examples to the world. And as we said earlier, purpose of PMAC is to bring these kind of perspectives and thoughts together. So I think this session really exemplifies, global leadership from the UN agencies, ground level work from what we saw from the M-Fund, and a strong national leadership from Thailand. So really a wonderful session that points out the value of PMAC. It brings together these disparate perspectives. And I know I learned a lot. And I hope you all are prepared to go forward in your professional lives, amplify this. And I will remind us, Dr. Santino had one advice. What can you do for this? He goes, tell the truth. So you can go forward and tell the truth and amplify the messages you heard here. And the fundamental underlying issue for all of this, to me, is humanity. It becomes a humanistic issue. How can you have people in your community that get services because they happen to have a national identity card? The person 10 meters away doesn't happen to have that card, so they don't have access to life-saving services. So the humanity that underlies all your work is really what brings us here. So thank you all for a terrific session. Thanks to the audience for your participation. And it is Friday afternoon, so there you go. Thank you so much.